All right. So that is about hypoglycemia. Now, if they have already received the glucagon and they're coming to you to the hospital, why do they come to the hospital? One, glucagon's side effect is nausea and vomiting. So sometimes these children might have received glucagon, but then they'll start throwing up and they cannot hold fluids, and the blood sugars can drop down further, even though the blood sugar is higher now. So we need to stop the vomiting. So sometimes it's useful to see them then. Okay. And then the last point, can they have infections? Yes, they can have infections. So child presenting with diabetic ketoacidosis, we need to remember they can present with some infection. I had a child some time ago where the child had an infection. It was in the gluteal cleft, an abscess. Nobody ever examined the child because they thought the child is autistic and diabetic ketoacidotic. We just have to take care of it. Guess what? DKA will not come down unless we take care of and drain the huge abscess this child had. So sometimes the child may not be able to stay because the child is developmentally delayed or the family is developmentally delayed, which you see all the time. Okay, so need to have a complete examination done. Last thing to remember, pump. If the child is wearing a pump, the site could be blocked. And if there's no infusion going on, even though the family is pressing on the numbers, the child may not be getting the insulin at all. So sometimes it's a good thing to just shut off the pump and then start IV insulin. And we don't have to take the site off. We can leave the site off, but just suspend the pump. The advantage of pump is you can shut off and start at any time, provided the site is all right. Sometimes site can be infected. The dictum is they have to leave the site only for 3 days. Sometimes kids leave the site for 5 days, 6 days. So fibrous tissue can form and block it. Sometimes the tube kink. I even had a kid who came to the ER once because when they put in the cannula, they didn't take the sheath off. So with the sheath, there was no insulin being delivered. Anything can happen, so keep that in mind. If they are in pump, doesn't mean the pump is actually delivering insulin. Now, the other thing is they'll always tell they're checking the blood sugars really well. Take the blood sugar monitor, ask them to show it, and you will be surprised to find that they'll have 6 blood sugar checks on that particular day, but 6 altogether the previous 1 month. Okay, so that is something to remember. Now, when you're evaluating these children, it is important to see what are the social circumstances they are in. It might be a split household. The child might have all the insulin in mother's house and the father might be having the child for the weekend. Okay, the child might be changing over from foster care to another foster care home who have no idea how to manage diabetes. And children do lie all the time. So whatever they tell you, take it with a pinch of salt. Don't believe all that they tell. Okay, and they can put up a very straight face. I even had a child who was checking her cat for blood sugars for a period of 1.5 years before we actually found out it was all her cat's blood sugars, and the cat didn't have diabetes, so the blood sugars were all fine. Hemoglobin A1C was 15.5%. So they can tell all lies. The parents will also tell all lies. Remember, the families and the patient wants to please you. They want to feel their nurses and doctors like them. So they'll always tell lies, not because they want to destroy themselves, but they want to feel good about it. So remember that. And sometimes they also become very defensive. So we don't have to point fingers on how bad they do a job, because if we have diabetes, to check 4 times a day and give 5 shots a day and live with diabetes every single day, it's not fun. So sometimes we have to be careful about being judgmental on them too. So be careful about talking to them and give a little bit of leeway for them to get over their mistakes and be supportive when you talk to them. Sometimes all they need is, don't worry, everything is going to be fine and we are there for you. Okay, that's very important. So make them feel good about that. Make eye contact when you talk to them. I'm sure you're doing that with all the patients. Same thing applies to the kids as well. Just hold their hand and tell things are going to be fine. And sometimes you might be the person who's making the biggest difference in their life, and all the attempts we have made in the past might be all bad. So that's why I always tell, there's no I wanted to say there's no I in the word team. So we are all together to make these children good. And again, if you identify social problems, if CPS need to be informed, they need to be informed. Okay. Now, what do we actually do when we send a child home? So when a child is presenting to the hospital, you have to remember we have taken a lot of precautions to make sure they don't come back to the hospital. Any new child who's discharged from the hospital, every single day they talk to the doctor at 6 o'clock in the morning to give a blood sugar report for the entire day, the 24 hours prior to that. So every child, every family calls every day for a few days before they become settled. We see them within the office within 1 week. We see them with the team within a month's time, sometimes within 4 to 6 weeks. We make sure they have all the supplies available. We contact the school. We give a school form for them to manage diabetes at school. So we take care of all these little things so they don't show up in the hospital. In addition to that, they have access to us 24/7. They have social support through Facebook. They have social support through Yahoo group, and there are parents who have been trained to support them, not medically but social needs, how to manage, how to deal with insurance company, how to deal with school. We also are open to training extended caregivers like uncles, aunts, grandparents. So we do all these things. So in spite of that, if the children are showing up to the hospital, we need to identify what the problem is. Majority of the time it will be non-compliance or a social issue. Sometimes it could be an infection, it could be a pneumonia, it could be a site infection with a pump, so on and so forth. But majority of the time it's a social issue. Okay. So the last thing I want to stress here is we consider them to be our family, not a medical care team. So when they come to us, I always tell them, you have inherited a non-English speaking uncle. And that's how, as a team, they're all English speaking except me. But the fact remains that they are our extended family and we are their extended family. And sometimes we all fight with each other, but we still put up with each other because we are family. Okay, transition care. Beyond that, we also concentrate on a lot of social issues. We do school nurses training. We do parents training. We also do something called as S to college, where we teach them about how to transition on to adulthood. Not just managing diabetes, but talking about their school, how to apply for SATs, how to apply for scholarships, financial aid. Our goal is that they should not have complications. They should have a full, healthy, useful life. They should be good citizens and they should be trouble-free. For that to happen, it should be a whole life management and not just diabetes management. Now, going back to the story, God then brought forth running shoes so that his children might lose those extra pounds, and Saturn came forth with a cable TV and remote control, so man would not have to toil changing the channels, and man and woman laughed and cried before the flickering light and piled on the pounds. Alright, so commitment, as I told you, we have an entire team which is working for these children because it's a chronic disease. Child, the parents, the extended family, the school, the primary medical specialist, the diabetes team, the community and government.